And for all the panelists and the audience, thank you for a wonderful session. I know there are many more questions, but I think we'll take a break now for 20 minutes and come back at 6 p.m. Riyadh time sharp for the talk by Dr. Daniel Riew on cervical spine anatomy.
And you can start.
Okay, thank you very much. I saw that there were 4 lectures in a 2-hour slot, so each lecture is about 30 minutes. Is that correct?
Yes, correct.
Okay.
Yes.
All right, I'll leave some time for questions also. All right. So thank you for that. And these are my disclosures. I do get some royalties on an anterior cervical plate. So I decided to make this lecture in the form of a question and answer session. And that way people can, rather than just listening, try to think on their feet and try to come up with the answer. So which of these, A or B, is in the PARS of C2? And this is a surgically relevant anatomy lesson rather than just a straight anatomy lesson because anatomy can be very interesting, but it can also be very boring for people. So I made it a surgically relevant anatomy talk. So a lot of people get confused as to which of these is in the PARS versus the pedicle. And so it's good to know when you're that we're all talking about the same structure.
Excuse me, Dr. Daniel, could you share your screen, please?
Oh, I thought I had. Sorry. Let me just see. Let's see. Okay. I think you have to allow me to, the host has to allow me to do that, right?
Yeah, you would find.
Yeah, it says host has disabled screen sharing. Oh, there we go. Now we got it. All right, can you see it now?
Yes, thank you.
Okay, all right. So let me go back and okay, so which of these pins is in the C2 PARS? And then the other question is, which of these is more likely to injure the vertebral artery if you have someone with normal vertebral artery anatomy? And that's the relevant part of using a PARS versus a pedicle screw. And the answer is that this is the pedicle screw. So the highlighted translucent red mark is the pedicle of C2. So if you start that screw at the leading edge of the lamina of C2 and just lateral to the midpoint of the PARS of C2, that's a good starting point. And then you angle medially to get into the pedicle of C2. Now, if you do that, it actually lowers your chances of hitting the vertebral artery. If you look at the cartoon at the bottom, you see the red arrow and the green arrow, and you see where the artery is. The red arrow represents the trajectory of the PARS of C2, and it runs parallel with the vertebral artery. So if you angle that trajectory a little too ventrally, it will hit the vertebral artery. However, with the pedicle screw, you start a little bit more proximally, a little bit more cranially, and that's about the only place you can hit the artery, because from then on, you're angling medially and away from the vertebral artery. So a pedicle screw, if you don't hit the artery when you first start, and you really shouldn't, because the artery should be much more ventral and lateral at that point, and angle medially, you should not hit the vertebral artery. Now, there are anatomical differences amongst patients, so you do have to check a CT scan to see where the foramina actually are. Okay, if a C1 lateral mass screw is too long, what structure is it most likely to injure? Is it likely to injure the hypoglossal nerve, the glossopharyngeal nerve, the esophagus, the vertebral artery, or the internal carotid artery? And the answer is the internal carotid artery. And this was demonstrated by Brad Currier and his group at Mayo Clinic. And he showed that the internal carotid artery is actually quite close to that anterior aspect of the C1 lateral mass, and that it is at risk if you put the screw in a little bit too long and a little bit too laterally. It is on the lateral aspect of that area. So as long as you angle medially, you're less likely to hit that artery. But it used to be said before Brad pointed this out that you can leave that screw long, it's not going to hit anything bad, and you don't have to worry about it. The esophagus is a midline structure. The hypoglossal, the glossopharyngeal nerves are more anterior to that, and it's very unlikely to be injured. A nerve gets deflected when you put a screw because it's mobile. The artery is more tethered down. It's a much larger structure, and that's why it's the internal carotid artery. What muscle is the most important extensor muscle of the cervical spine? Is it the longissimus cervicis, semispinalis capitis, the semispinalis cervicis, the splenius capitis, or the splenius cervicis? The answer is semispinalis cervicis. It originates out of the transverse processes of T1 through T5, and it inserts between C2 to C5. It is the most important extensor muscle of the neck. And the most important insertion is actually at C2. So if you detach it from 3, 4, 5, you will lose a little bit of extension at those levels, but you'll still be able to extend your neck. Conversely, if you detach it off of the transverse processes of T1, T2, T3, T4, and T5, you'll tend to have the neck sagging. Now, why is this important? Because you use transverse process hooks and you detach all of those muscles from there and you don't do a good closure, then it can lead to proximal junctional kyphosis. That's why you got to make sure that you don't detach those muscles. And if you do, you have to reattach them and close the wound very carefully. And this is probably the muscle that is most involved when you have a primary cervical myopathy or a dropped head syndrome. If you take a look at the x-ray on the right, you'll see that it is lordotic at C2, 3, and 4. That's because the muscle is still tethering there. And as it gets stretched from C4 all the way down to the thoracic spine, the patient develops a markedly abnormal cervical thoracic alignment. And it's due to the fact that this muscle has become elongated or has gotten very weak. Okay, what is the purpose of the C7 and T1 spinous processes? Is it important because that's where muscles attach? Is it because it provides biomechanical advantage to allow you to extend your neck? Or is it just an unnecessary remnant like the appendix of when humans became bipeds instead of being our earlier ancestors were quadrupeds and walked on all 4 limbs and needed to hold their neck up in that position and needed to have large spinous processes. So is it the attachment of muscles, biomechanical advantage, or is it an unnecessary remnant that we can do without? The answer is that the spinous processes allow for a biomechanical advantage so that the extensor muscles that go over C7 and T1, and that's C7 is obviously called Vertebra Prominence because it's got a very prominent spinous process. You can think of it like these suspenders. When you have a suspension bridge like the Golden Gate Bridge on the left bottom, you have the suspenders. And it provides a biomechanical advantage so that you can lift up the bridge. The lower this is, the more the cables sag and the more the bridge will sag. And in the same manner, if you did not have a large spinous process, then the muscles will be flat against the lamina and it won't have the biomechanical advantage to pull on C2 to extend the neck. That's have a very tall spinous process. And that's why if you do a laminectomy of C7 and T1, the patient's neck muscles become elongated, they sag, and they tend to fall into kyphosis. And you can see this in this laminectomy where somebody's had a laminectomy all the way down into the C7 area. They no longer have that biomechanical advantage, and they tend to fall into kyphosis. Which of the following is the strongest ligament in the mid-cervical spine, say between C2 to C6, C7? Is it the supraspinous ligament? Is it the interspinous ligament? Or is it the yellow ligament or ligamentum flavum? This is a trick question. And the trick question has to do with the fact that there is no supraspinous ligament. There is no interspinous ligament in the cervical spine. Now, most people think that there is, and a lot of anatomy books have them, but in truth, it does not exist. Only the ligamentum flavum exists. Now, it's not a strong ligament, but it is the only ligament that exists in the cervical spine and the mid-cervical spine. The ligamentum nuchae, or the nuchal ligament, goes from the external occipital protuberance to C7. And in quadrupeds, like horses, this is very thick because it needs to hold their head up. It helps hold the head up. Below that is where the supraspinous ligament starts. At C7, it goes all the way down to about L4, L5 or so. And so there is no supraspinous ligament. Now, we call it the supraspinous ligament complex, but in fact, in the cervical spine, it is technically the nuchal ligament, and therefore there is no supraspinous ligament. Now, what about the interspinous ligaments? If you look in Google and you look at these pictures, you'll see the red the red circles. They show interspinous ligaments. So there must be interspinous ligaments in the cervical spine, right? Absolutely not. In fact, what you see there is an interspinalis muscle. It's a muscle, it's not a ligament. By the way, if anybody ever finds a ligament between the spinous processes, between C2 down to C7, please biopsy it, send it off for pathologic examination, take a picture and send it to me. The next time you dissect back there, see if you can find it. And if you find it, please take a picture and show me the ligament. In fact, when we do meticulous dissection, we come right down the middle. And what we do is we take everything off. It's because it's only muscles. You take all the muscles to the left, all the muscles to the right. Most people, when they say I'm preserving the interspinous ligament and cut on either side of the spinous processes, they don't realize what they're doing is devascularizing the interspinalis muscle. They're leaving that muscle to die and afterwards become a nidus for an infection. So you want to cut right down the middle so that when you're done exposing the spine, there's nothing left but air between the spinous processes. Do not try to preserve a supraspinous ligament. Do not try to preserve an interspinous ligament because they don't exist. Divide the nuchal ligament right down the middle, and that way you'll preserve its vasculature. There is no structure in the human body that can survive without blood. And if you cut the blood supply from the right and from the left, all structures without blood supply in the body will die. So the answer is ligamentum flavum, because A and B do not exist in the cervical spine. This is one of the most common misconceptions I see all the time when surgeons say, here's the ligament and I'm preserving the ligament, I'm cutting on either side of it. Which nerve is never part of the brachial plexus? Is it C3, C4, T2, or all of the above ever part of the brachial plexus? And if you were listening to the last lecture, you would know the answer to this because it was very well covered, that there is such thing as a prefixed brachial plexus where the C4 nerve actually partially innervates the deltoid. And that can exist up to maybe even 48% of the cases. And the postfixed brachial plexus, the T2 nerve root can be part of the brachial plexus in 5% of the cases, which means that both of those can be part of the brachial plexus, and only the C3 nerve root is the one that cannot be part of the brachial plexus, has never been shown to be part of the brachial plexus. So C4, 5, 6, 7, 8, T1, and T2 all can be part of the brachial plexus, although the most common ones are 5, 6, 7, and 8, and T1. After a C3-4 ACDF, a patient cannot sing high notes. What is the injury? Did they injure the vocal cord? Did they injure the recurrent laryngeal nerve? Or did they injure the superior laryngeal nerve? And the answer is the superior laryngeal nerve. This has two branches. The internal branch is mostly sensory, and usually it comes in from both sides. So you can injure it on one side and still feel things when you swallow. Now, if you can't feel things in the back of your throat, you can aspirate. So it's very important not to injure this. On the other side, if let's say you had an approach done on the right side up high, you injured it, you didn't know it. And then you go in and injure it on the other side. Now the person can't feel anything and they aspirate and they need a permanent peg to prevent aspiration pneumonias. So you have to make sure that this is intact by having your ENT doctor check specifically for the superior laryngeal nerve. They do a video fluoroscopy and they can take an examination of that area and see if it has been injured or not. There's also an external branch, and that's what you tense when you tense the cricothyroid muscle, and that's what allows you to scream and sing high notes. And so that's the external branch to the motor aspect of the cricothyroid muscle. So that is what you have injured if you cannot sing high notes, but can otherwise have a reasonable voice. If you injure the recurrent laryngeal nerve, you paralyze the vocal fold on one side, and so you end up talking like this because the vocal folds cannot close. So one side is open, there's too much air that goes through, and that's why you end up with a very breathy kind of a voice. And what they can do to fix that is they can put a cartilaginous shim to push the normal vocal fold over to the abnormal one so that it can open and close and get about 80–85% of your voice back with a recurrent laryngeal nerve palsy. Now, upon awakening from a posterior foraminotomy, no anterior procedure, the patient has a hoarse voice. What is the injury? Did they injure the vocal cord? Did they injure the recurrent laryngeal nerve? Did they injure the superior laryngeal nerve? Or was it an arytenoid dislocation? Well, that sounds interesting. Well, it's not surgical because you can't injure any of those structures from a posterior approach. It must be anesthesia. We always end up blaming anesthesia for everything. And the answer is, this is an arytenoid dislocation. It's something that most surgeons have no idea what this is, but it can occur. And it's curable if you relocate it, but you got to do it within a short period of time after it's been dislocated. Otherwise, it stays in that position. And then the ENT docs have to do surgery to fix this. It can dislocate either anteriorly or posteriorly, and it's usually due to intubation. So with an anterior displacement, what happens is the laryngoscope blade goes in, it goes in too far posteriorly, and when they flip it this way, it dislocates anteriorly. And with a posterior displacement, what happens is the endotracheal tube cuff goes in and it pushes too far posteriorly and it dislocates posteriorly. Or what ends up happening is they don't deflate the cuff when they pull the tube out, and that cuff ends up pushing the arytenoid posteriorly, and you end up with a posterior dislocation. And how do you know that this is due to this? Well, you can get a CT scan, and this is an ENT exam of what it looks like, but a CT scan will show you a dislocation, and you can see what it looks like with a scope, and you can see what it looks like on the CT scan. Now, as I said, it's most commonly due to a traumatic intubation or extubation. And what you'll see is that the patient will have a hard time talking, but they will not have any difficulty with swallowing. This is different from a recurrent laryngeal nerve palsy, where you will have a hoarse voice and the person will say that I can't swallow. And so if you have somebody with this and they say, I can't talk, but I can swallow, get an ENT evaluation right away. They'll get a CT scan and then they can relocate this arytenoid dislocation. Now, C1 lateral mass screws. Is this a good trajectory for a C1 lateral mass screw, or is it a bad trajectory for a C1 lateral mass screw? And the answer is that it is most likely a bad trajectory. It's a little too high. Ideally, you should aim for, on the very left side, you see 40%, 20%. It's the bottom 40% of the C1 anterior arch between the 20th and the 40th percentile of that anterior arch of C1. Why is that? Because the C1 lateral mass looks like a bow tie. And the more medial you go, the closer you are to the occipital C1 joint, and the more you can violate it. And what we found is that if you stay under that 40% mark, you will never violate the occipital-cervical joint, as I did in this case that we reported. And in this case that was part of that paper, you can see that I ended up violating that occipital-cervical joint, and I ended up having to remove that screw before it caused traumatic arthritis of that joint. And you can see on the lateral image that C1 lateral mass screw is just a little too high. Now, how about this? This is low enough. Are these good C1 lateral mass screws? They look pretty good. They look like they're in a good position. And are these good C1 lateral mass screws? They too look like they're in good position, and they look like they've got good purchase. But the answer is they are not. They're way too long. Because if you go to the point where the C1 lateral mass screw is flush with the anterior cortex of the C1 ring, then you are way anterior to the lateral mass, and you're in the territory where you could hit the internal carotid artery. So you must be careful not to leave these screws too long. You want to be flush with the posterior aspect of the anterior arch of C1, not the anterior aspect of the anterior arch of C1. And what are acceptable starting points for C1 lateral mass screws? Is it A, B, C, or all of the above? And the answer is that you do not want to put it in A, B, because A or B, this is called a ponticulus posticus. It looks like a very wide posterior arch of C1, and what's under there is actually the vertebral artery. And so even though it looks like a great place to put a C1 lateral mass screw, if you see that the lateral aspect of the posterior arch of C1 flares up cranially, avoid it because it is a ponticulus posticus. You can see that there is a ponticulus posticus by looking at a lateral C-spine X-ray and see that there is a bridge of bone, and it's called the arcuate foramen within that. During a C1 lateral mass screw placement, there's massive pulsatile bleeding between C1 and C2. This can be due to, is it a vertebral artery? Is it an engorged venous plexus? Is it an intersegmental artery? Is it A and C? And the answer is, it is A and C. This is an example from Jinsap Yum, who is from Seoul National University, Bundang Hospital. And you can see that the vertebral artery is anomalous and actually is between C1 and C2. And then there's an intersegmental artery on the left side that's also off of the vertebral artery. And so you can have these anomalous vertebral arteries. You can have an anomalous vertebral artery that sits underneath the arch of C1 instead of cranial to the arch of C1. And again, so if you see pulsatile bleeding there, it's not going to be the venous plexus because veins don't pulse. It can be a persistent intersegmental artery or the vertebral artery. Best landmark to determine a thorough decompression during a posterior foraminotomy. Is it A, the lateral border of the pedicle, B, the medial border of the pedicle, C, you remove 50% of the facet joint, D, you decompress until the ganglion is free? And a lot of people who do foraminotomies don't know what the boundaries of the foramen are. It's the cranial and caudally, it's the pedicle at the level above, pedicle at the level below. Anteriorly, it's the uncinate and the disc. And posteriorly, it's the superior facet. So at C5-6, it's the superior articular facet of C6. And that's what compresses the nerve. So if you want to get out laterally, you have to go lateral to the pedicle because the pedicles define the foramen. And the way you do that is you look for what I call the interlaminar V between the lamina of C5 and C6 where they meet. What is important about that is that just about where they meet is the medial border of the pedicle. And the foramen goes from pedicle to pedicle. So you need to go to the lateral border of the pedicle. So the first thing you do is you remove enough of C5 to expose C6. You remove enough of C6 in order to expose the pedicle and the lateral aspect of the pedicle, because once you have done that and removed that L-shaped trough, then you have removed all the pedicular overhang, and then you are lateral to the pedicle and you're no longer in the foramen, and therefore that nerve root is now completely freed up, and you have done a thorough job of decompressing that nerve root. So I thank you for your kind attention, and I hope that you have picked up one or two points about the anatomy of the cervical spine. Thank you.
Thank you, Dr. Daniel. Can we have a question now? Question from Yasser Abdullah. What could be the cause for C5 palsy after posterior fixation without laminectomy from C5 to T4?
So C5 palsy has been postulated to be due to many different things. The number one hypothesis is that it is due to a stretch of the C5 nerve, because when you have a cervical lordosis, it is right at the apex of the lordosis, and when the cord drifts back, it tends to pull on the nerve and causes a stretch phenomenon. That is not the only hypothesis. Other people think that it is due to an injury of the cord itself. Some people think it's a rotation of the cord. As the cord rotates, it can cause an issue. And there's varying reasons to believe each of those. For instance, the cord as an issue is supported by the fact that patients who have a cord signal change at the C4-5 level have a much greater chance of having a C5 palsy. Foraminal stenosis has been implicated, so some people advocate doing a prophylactic foraminotomy, but other studies, including ones we did, show that prophylactic foraminotomies did not make any difference, and other studies suggested it does make a difference. So it's still controversial.
Any other question?
Yes, I would like to ask, if you allow me. First, I would like to thank Daniel Riew for coming back to Spine Update. I think the last time he presented in Spine Update was 7 years ago. So we hope to see you in person next time. I have a question. You emphasized the role of the muscles in the posterior cervical spine exposure. What advices would you give around exposing the muscles around C2? If you're going above C2 or going below C2, is there any way during dissection that you'd preserve those muscles?
Yes, I come right down the middle and I go subperiosteally and leave as much of the muscular attachment as possible. So for instance, if I'm coming from the caudal aspect, what I will do is, let's say I'm doing a laminoplasty. Taguchi has shown that it's better to do a C3 laminectomy instead of a laminoplasty, because to do a C3 laminoplasty, you have to detach a lot more of the C2 muscles, and a laminectomy doesn't require that. If you're coming from the top, leave the semispinalis muscles attached on the caudal aspect of the C2 spinous process and lamina. Only detach the semispinalis capitis, the rectus capitis, and all of the muscles that go from the cranium down into C2. So leave as much of the muscular attachment as possible. And then when you're closing, you got to close very meticulously. For me to close from C2 to C7, I use about 150 sutures. It takes me about 45 minutes. And what does that achieve? It means that, one, it doesn't bleed much postoperatively. Number two is that the wounds don't dehisce. Number three, the patients have a lot less pain. And number four, you will eliminate infections. I have not had an infection in the posterior cervical spine since 2005, over 1,000 cases ago. And if you just close like I do, you too will never have an infection in the posterior cervical spine. Is it worth, it used to take me 15 minutes to close the wound. Now it takes me 45 minutes. Is it worth that extra 30 minutes? Absolutely, because I don't worry about infections.